I'm probably going to transfer to my phone rather than on this.
Okay,
I'm going to try. Let's see.
okay. Good morning, Yosef.
Good morning.
You have the snowy scenes of Inwood behind you, I see.
This is the 185th Street Plaza. This
All
is,
right.
I think I took it on Monday
Oh, okay.
or Tuesday, yeah.
Oh, yeah, it is. Well, I didn't take any pictures of the outside because I was homebound. Me and my rollator don't do well in, that much snow or ice. So I'm hoping, I was telling somebody I'm hoping to get out this afternoon for a little bit. I'm feeling
we
like
got
I'm feeling like I started to feel with the COVID, Ugh.
Yeah, we got 21 inches up where I was.
Wow. And where is that?
Irvington, near the Tappan Zee Bridge.
Okay. Yeah. It's a lot for the city.
Yeah.
Where I come from, that's used to be the norm, not anymore though. I come from upstate New York near Canada. So sorry. Spam call.
Mary, you'll pardon me if I'm a little bit in and out this morning. My daughter just gave birth to a baby on Saturday and she's recuperating in my house.
Oh,
So-
congratulations.
Yeah, so I'm running a little bit back and forth, but I'll try to be
Okay.
here as much as I can.
No problem.
That's exciting.
Olga Zoom webinar.
Good morning, Mary.
Oh. Good morning.
It's Liliet. How are you?
Okay, how are you?
Pretty good.
Morning, Fern.
Hi, everybody. Good morning.
Good morning.
Good to see you again, Stephen.
Good to see you.
Good
Hi,
morning,
Lady.
lady.
How are
Good
you?
morning, Mary. Hi, Fern. Hi, everyone.
It's so cool to see everybody, sort of.
Yeah.
There's Shuli. Hi, Shuli.
Hi, Shirley. Oh my God.
Oh my gosh.
Oh.
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 You're
Oh,
on
how
mute,
precious.
Shuli.
Oh, precious. Wow.
Wow. A new grandchild, Shuli? You're on mute, honey.
She said
Sorry, yeah.
Saturday. Yeah.
I said, yeah, he's 5 days old.
Oh, how fantastic.
His mommy needs to sleep. We're trying to keep him happy. I think she has what he wants and I don't, but yeah.
As happy as he can be.
Right.
Oh, yawning. So cute.
Mhm.
Well, none of us slept more than an hour straight last night, so that's why the yawning. He'll be fine.
Hey, please. Hello.
Julie, what's the name? What's his name?
So we named the baby at the circumcision. So we've got a couple of days to go. So he's gonna be, he was born on Saturday, but he was actually in the NICU for a couple of days, so he's not gonna be circumcised until Monday. So we'll know Monday.
And this is your daughter's?
This is my youngest daughter's
Yeah.
child.
And how is she doing?
So she had a C-section, so she's recovering, but you know, it takes a little time. But thank
Yeah.
God she's doing well. She's doing well. Healthy baby, that's what we wanted, so.
Wonderful, wonderful.
Hungry baby.
Oh.
Good morning, Maria.
Good
Morning, everybody.
Good
are
morning,
you?
Maria.
How are you doing?
We don't know yet.
You don't know yet, okay. I hear you. Ebenezer, is that Carol you're talking to?
Where's Maria? Maria,
She's here.
Yes.
She's there.
I just emailed you your latest list update, and I'm halfway through the one you sent me yesterday.
Okay. Thank you. I sent you something last night, right?
Yes, and I think that this feedback loop is actually working better for us
Uh-huh.
because now you know exactly what we're, who has appointments and when, and who we can't reach.
Okay, because I just got a second ago a call from a lady. We registered some time ago, long time ago, and
Oh.
they haven't received. Her name is Leda some. Oh my God! And she's like 90 some years old, and she's desperate.
So why don't I
Leda,
call you?
uh-huh.
I'll call you after this meeting for the particulars. How's that?
Okay, because I'm going there today to have my second shot. I hope they
Right.
find my name.
They'll find your name. I already got an email back saying that you could go anytime you want because you're already registered for it.
All right, thank you.
Yeah.
All right.
Yeah, that's what they say, yeah.
Yeah,
Ebenezer,
because of the cancellations.
hold
from
on,
Tuesday.
ladies. Ebenezer, was that Carol you were talking to?
It was Maria.
It was Maria,
I was
okay.
helping her to
Carol-
come to the meeting.
Carol's
Carol is
having
there?
trouble getting on.
Uh-oh.
Okay.
Hi, Maria.
Okay, Richard Allman is there. You need to be promoted. I'm gonna do that, Richard. Okay.
Early morning is not my good day. It's my good time, my bad time, my every time.
Not mine either. And people are calling me before 9.
Oh, yeah.
So
I'm like,
Carol,
oh, please
she's
don't call me
calling
before 9.
Me
on the
No,
phone.
me too. I got called at 6 o'clock in the morning. I get called
Me
at midnight.
too. I was like crazy. What are you doing calling me at 6 in the morning?
Yeah.
Good morning,
I
Richard.
had, I think 50 calls over the weekend, Maria.
Oh, I'm sure you did, because I've been telling everybody, please, this is, you have to have patience. This is the thousands of people doing the
Right.
same thing, and they just don't understand it.
Right. No, I'll take that name from you because well, let's see what's going on.
Yeah, okay.
All right. Hi, Richard.
You're on mute, darling.
You're on mute, Richard.
There you
That
go.
came from the folks who know me, but I wanted to say a special welcome to the folks who are new to the meeting.
Good morning, Verna. Welcome.
You're on mute, Verna.
Yeah. Oh, well. waiting for,
Carol?
well, and the other speakers too. We have Dr. Mara Minguez.
Yeah, she said she might be running late. So, I mean,
Okay.
I'm the one that will be giving the actual presentation
Oh, okay.
or doing the discussion.
No problem.
And then I think she did email me earlier that she might be running late.
Okay.
So I just want to give you the feedback, Stephen, that my staff who participated in the training that you did with Waikoa said that it's been really helpful. We had a casework meeting yesterday, and most felt that especially the tips on hesitancy were helpful.
Oh, that's great. So was that Dodie that did that, right?
It was Dodie and Mara.
Okay. Oh, great.
Yeah. Well, Mara sort of introduced Dodie, and then Dodie took it from there.
Right.
Hi, Chris.
Hi there, everybody. Mary, I'm happy to speak about the wellness calls if you want to flip the agenda around. Whatever works for you all, I'm available.
My only, I have clinic at Harlem United. I have to be there by 1 o'clock, so that's my only timeline.
Oh, we're done by 11. Even if you're at the end of the agenda, you'll be there.
11:30 maybe.
Mary, you're on mute.
Sorry,
Are we
12.
ready to get started, Mary? You're on mute.
You're on mute, Mary.
Sorry, it's 10:42, so I'm going to call this meeting to order. Welcome, everybody. I don't know how many of the committee members saw the posting from Paola about committee structure. And I think the young lady will be trying to get on the call. Cindy Matos has now been assigned to our committee. So, you know, we will welcome her as she comes on board. And very happy to have another committee member. So I think she'll be a great asset. Let's go through and I don't know. Let's go through introductions, make sure that our presenters and everyone else knows who's who. I'm Mary Anderson. I'm the chair of this committee. Joseph?
Hi, Joseph Kalinsky, Assistant Chair.
Liliet, could you introduce yourself? You're on mute.
Liliet
ahead.
Lopez, Outreach Specialist of Night Connects.
Okay. Fern?
Fern Hertzberg, Executive Director, ARC 16 Fort Washington, and co-chair of the Washington Heights Inwood Council on Aging.
Maria?
Maria Luna, member of the board of the committee.
Richard?
Member of the committee and site manager for one of ARC Fort Washington senior centers.
Chris? Chris, you're on mute. There. Okay.
Chris from Senator Jackson's office. You can use they, them pronouns with me or just call me Chris. And I am here as a guest on the agenda.
Lady?
Lady, Senior Center Director at Star Senior Center.
Glennis?
Member of the committee, and I am the Chief Administrative Officer at the Armory Foundation.
Ilana?
Hi, Ilana Dunner, Riverstone Executive Director, Riverstone Senior Life Services, and I'm going to put myself away, but I'm here.
Julie? Julie's taking care of the baby, but Julie is the director of the Mariah Senior Center. And Ebenezer?
Hi, Ebenezer Smith, District Manager, Community Board 12, Manhattan.
Thank you, everybody. All right, so our first presenter will be Dr. Stephen Chang from Columbia, from New York Presbyterian, and he's going to be presenting along with Dr. Mara Minguez, who will be on board in a little bit, about the vaccines for COVID. So The floor is yours.
Okay, so I'll try to share my screen. Oh, is there a possibility of sharing the screen? I think it has to be released.
Ebenezer?
Yes, how may I help?
He needs to be, Dr. Chang needs to share his screen. Can you?
Okay.
So I'm actually a nurse practitioner, not a doctor, but I've been working here at Columbia University and New York Presbyterian for the last 20 years, mostly doing HIV primary care as well as sort of population health initiatives to help end the AIDS epidemic. So that's been most of my role up until this last year, and now that's been primarily transitioned into work around COVID. And so during the peak, I was overseeing the clinical workflows for the COVID tents that were outside of the emergency departments. We were offloading the EDs with caring for the more mild to moderate cases. And so we were in the tents, 24/7, practically 12 hours a day for 7 days a week during the peak. And then after that, it was really transitioning over to sort of supporting testing and infection prevention and control. And I did a lot of work with a number of community-based organizations to help think through how to safely reopen and talk through the workflows and all of that. So that was really rewarding. And now I'm getting more involved in the whole sort of vaccine effort. And so we have a speakers bureau that's been going around to a number of community-based organizations, as you just heard, in terms of WICOA, to really engage in that sort of open conversation about the COVID vaccine and the questions that people have, and sort of just raise general awareness and have those conversations. So let me try to share. And again, I think I saw an agenda where it was about 30 minutes, which is usually how long it takes to do the presentation. And I think a more valuable part would be to actually get through the slides fairly quickly so that we can really get into the meat of the discussion and the questions, if that's all right with you. Because I think that's probably much more interesting. So I may skip over a few slides because it's probably very basic at this point, but I'll pause on a couple that might be worth elaborating on. So this is just the basics, and obviously this is a moving target because of the new strains, but the route of transmission are droplets. They drop within a very short range. Most of them are fairly large, but then a smaller subset of them, especially if you're talking loudly or singing, are much smaller, and they can hover in the air for a bit longer. So again, that's the whole reason why being indoors and closed spaces with poor ventilation, it poses a risk, mostly if you're within that 6-foot range, but even beyond that, if there's definitely a lot of loud talking and singing, and that's why sometimes, in a church setting and or definitely, restaurants and bars, they've been very cautious about that. And a lot of people are trying to highlight, like, what are the major reasons why I would consider getting vaccinated? And one of the number one reasons is it causes people to become sick, and it can, we know that it can range from sort of mild disease to actually quite severe, and then ending up in the hospital. Right now, the hospitalizations are dropping, which is phenomenal. Every time I do this presentation, even by day, it was 120 the other day, then it was 100, and now it's 91, which is fantastic. But the death rates continue to rise. As you saw in the New York Times this morning, we passed 450,000, and that will continue to rise because the patterns of death rates always fall behind the patterns of infections in the community and case rates. So that will continue to rise for some time, unfortunately. And this is probably the number one reason to get the vaccine. And some of these symptoms really hang out for a while, and there's lots we still don't know. There's strange long-term complications in multiple systems in our body. So it can directly affect your heart. We've seen people have changes in the heart muscle structure. especially those that have underlying kidney disease. We've seen pretty dramatic worsening of kidney function, and that doesn't necessarily reverse. Then those that are predisposed to getting clots, there's increased risk of clot formation, which can lead to strokes. There's direct effects on the brain. There's been described this sort of sense of brain fog, and affects the nervous system through systemic inflammation. And of course, it directly targets and attacks the lung. And people, we've had physicians that were infected early on that had months of respiratory problems afterwards. So again, all, really good reasons to get a vaccine. And then on top of that, there are case reports, although it's not super common, of reinfection. So just having been infected before doesn't, protect you completely from reinfection. We don't know how long sort of that protection lasts post-reinfection. We've seen sort of post-infection antibodies sort of go down over time. And they do speculate that the immune response that the vaccine induces might be stronger and last longer than the immune response you get from having been infected. So it is recommended that if you have been infected, that you should also get the vaccine. And what's the number one reason? This is really our only ticket out of this. And it is by far the most powerful public health tool we have to deal with infectious diseases. And just looking at the measles alone, before we had a vaccine, there were 530,000 cases annually. So that's all cases, whether they get mild disease or severe disease. And then post-vaccine, that dropped to, in 2019, to 1,287 in a year. So that's a greater than 99% drop in infections due to the vaccine. And that's a vaccine that's highly effective. That's like a 95% effective vaccine, similar to what we've seen with Pfizer and Moderna. And so you can see with all of these, it's lowest is 92%, all the way up to 100% decrease in disease related to these infectious diseases. And wouldn't it be fantastic if we come back to this graph next year, and we went from, so far in the US, 26.5 million cases. That's quite a bit bigger than what we're seeing here, and 450,000 deaths. If we see the rates plummet in the same way that it does for these other diseases, and we return to our pre-COVID lives, and not to mention all the morbidity and mortality and trauma that this has caused. So, and really, truly, vaccines are the only way out of this. So I'm going to skip go through the science of the immune response, but bottom line is the way vaccines work is it's like showing a mugshot of the bad guy. Here's coronavirus. There's proteins that stick out of coronavirus. These are called spike proteins. And the way all these vaccines work is trying to teach your body to recognize just what that one protein looks like. So if it ever saw coronavirus, it would recognize it immediately, jump on it, and then kill it. And they use both the cells, there's T cells and B cells, as well as antibodies to do that. And so we're not using any part of the actual virus. There's no weakened coronavirus in these vaccines. There's no killed coronavirus. There is no coronavirus in these vaccines at all. All we're doing is getting your own body to make exact copies of just this protein, and then showing that to the immune system so that it can recognize that particular protein. So that's the way all these vaccines work. So I'm going to spend a little bit more time on this slide set. This slide where these vaccines are using messenger RNA, the Pfizer and the Moderna, and what that means is that so here's the virus, and there's this little scrap of genetic material that is the instruction manual for that virus on how to make that protein. And so what we do is we take just that instruction manual, just that little scrap of messenger RNA, and we package it in a little fat globule, because just like us, we like to eat fatty food. It's easier for these cells, this to get into the cell within this lipid packaging. And in the solution is also added a little bit of salts and sugar solutions to mimic our natural environment in the body. So basically, all that's in this vaccine is this scrap of messenger RNA wrapped in a fat globule in a salt and water solution, and that's it. There's no preservatives, there's nothing else in there. And when that gets into the cell, your cell reads the instructions and makes an exact copy of that protein that's normally found on coronavirus. And then it shows it to your immune system, and then your immune system makes antibodies that are specifically target that
Call
protein.
you back later. I'm in a meeting.
So this is
Just
why
hold on.
this
Let me
cannot.
make sure I write this down right.
so
646,
sorry?
what's the rest of the
Oh,
number?
Richard,
sorry.
you need to mute
Yeah.
yourself.
That's fine. So then, so as you can see, we're not using the virus in the vaccine, so you can't get COVID. And all of this is happening out here. It's not interacting with your own DNA. And also this particular messenger RNA self-destructs soon after it delivers its message. It's like if you ever watch Mission Impossible, this message will self-destruct, and then they get the information on how to fight the bad guy. Same thing with this vaccine. So that's more or less how this particular vaccine works. So, oh wait, hold on. Okay. So how do we know that these are safe? And they haven't skipped any steps in sort of the testing or the clinical trial process. Before they inject it into any humans, they're tested in animals. They start in a small number of people, 10 to 100 people, just to look at whether people are getting any side effects they wouldn't expect, as well as they're looking at in the blood whether it's developing an immune response to recognize what coronavirus looks like. And then they progressively increase the number of people in these studies to continue to get more information about how safe it is until you get to these huge studies that have tens of thousands of people. And I myself participated in the AstraZeneca study where they enrolled 30,000 people in the United States, and 20,000 get the actual vaccine and 10,000 just get salt water. And so when I was getting the needle in my arm, I had no idea whether I was getting salt water or the real vaccine. And then every day I had to report out how I was feeling. They would check my blood to see if I was, if my body was learning to recognize what coronavirus looks like. And then they were also, if I developed any symptoms, they were also testing me for coronavirus and to compare how many people get infected that got the vaccine versus how many people get infected versus the salt water, and also to look at how sick people get if you do get infected. And as we saw in the New York Times just released some preliminary data from AstraZeneca showing that it was incredibly effective, like all these other vaccines, at preventing, severe disease and hospitalizations, and even in the case of AstraZeneca, transmissions. So all of these vaccines that are either approved, Pfizer, Moderna, and then the ones that are right around the corner, the Johnson & Johnson and AstraZeneca, are all incredibly effective at preventing people from getting sick from coronavirus or getting hospitalized or dying. So they're just amazing vaccines. And so these are the two that are approved and are being used in the Armory. The one that we're mostly using in the Armory is this Pfizer vaccine. It's 2 shots, 21 days apart. It's approved for greater than or equal to 16 years of age. Again, it's been tested in tens of thousands of people, so at least half of these got vaccine. And already across the nation, I think it's exceeded 27 million people have gotten at least 1 shot. So that's a lot of additional people that, if they were having any problems with it, there's a pretty robust safety monitoring system in place if things that appear that are not expected. And I'll talk a little bit about that. And both of these vaccines are 95% effective. And what I mean by 95% effective, it's 95% effective at reducing infections in people that have symptoms. So they didn't, in these studies, they didn't test every single person over and over again. They basically, if you develop symptoms, they would test you because they were more concerned about whether it keeps people from getting sick. And you can see that in those that got salt water, they had, when they did this preliminary analysis, 162 people were infected, whereas 8 people in the vaccine group got infected. And you can see similar kinds of large numbers in the placebo and the vaccine. And none of these people that got infected in the vaccine group had severe illness, right? So they had mild cases, if anything. So incredibly effective. So a lot of people are concerned about how fast these came out. And the main thing I wanted to focus on why it came out so quickly is, one, because it's a pandemic and so many people were dying, that they threw a ton of money, they being, you know, the government and industry, at doing, normally they would do things in small phases so they don't waste money, right? So they do a, you know, phase 1 and they do some tweaking and then more phase 1s and more tweaking and more phase 1s, and then they'll do phase 2 and then they'll do phase 3. And they don't even start to make the drug until after phase 3 is completed and there's a you know, FDA approval process, and then they start making the drug. The main reason why this came out so quickly is that they were already building on, you know, decades of experience working with messenger RNA for other things. So they've tested this in cancer as well as infectious diseases. So they already had a lot of familiarity on how to work with this technology. They use clinical
I heard it was
trial
being
networks.
used for RSV, for children in RSV. That's what I heard last night.
That I'm not sure about. I'm not sure.
I mean, it was being developed. That's what I heard last night. That it was like 2
Okay.
weeks away. It was, the timing was unbelievable with the studying for RSV.
I actually think that there's going to be, this is going to be a boon for infectious diseases going forward. This whole thing with COVID has accelerated this technology. And what's cool about it is you can actually tweak it fairly quickly. So like in terms of the upcoming strains, if they do present a problem, they can actually tweak it to target the mutations that are happening in the protein outside of coronavirus. So it's very nimble that way. And then I think the main reason why it came out so quickly is that even before they had any idea of this product is going to be safe or effective, they just started making tons of it, sinking tons of money that could be a complete waste, right? So if it turned out that it was unsafe or that it wasn't working, they would have wasted all that money on the manufacturing, which normally they can't do. But because it's an emergency, they went ahead and said, we want this to be able to be distributed the moment that it's been proven safe and effective and that's gone through the FDA emergency use authorization process. So that's exactly what happened. We noticed that with Pfizer. One day, the FDA said, okay, we've had all our committees and all our experts look at all the data and all these studies and concluded that it's looking incredibly safe, unbelievably effective. We're in a state of emergency. Go for it. And then the next day, it was in Michigan, they were loading up these vaccines into trucks and distributing it. Rather than starting manufacturing, we would have been waiting for months. So that's, I think, the main reason why it came out so quickly. So I'm going to pause. Okay, so symptoms-wise, you know, I spend hours and hours vaccinating the elderly from our community in the Armory, which is like the best job ever, and they're so happy and thrilled. Some of them have very small deltoids, so I have to kind of pinch them up a little bit, but it's just an amazing job. So I'm going over and over again what you might get, and I also personally got the Pfizer shot. I had a pretty sore arm after I got the shot, and that usually in 1 in 5, that's about all you're going to get, and it lasts like 36 to 48 hours tops, and you can take Tylenol or Advil. But in 1 in 5 rather. So 4 and 5 get just the sore arm. 1 in 5, or about 10 to 20%, can get other symptoms, and that can be headache. I got a headache. It was mild. It only lasted a short time. You can get fever, muscle aches, chills, maybe a little nausea. And what I tell them, it's not necessarily a bad thing. That's a sign that the vaccine is just doing its work. That's just a normal effect of the body learning to recognize what the bad guy looks like, and it kind of gets excited and it causes some of these symptoms. It lasts for about 36 to 48 hours tops. And we tell people that if you're getting fever on day 3, it's probably not the vaccine, and there's still COVID out there. So then you'd really need to. At the hospital, if that happens to us, they want us to isolate. They want to swab our nose to make sure we didn't pick up COVID from the community. So that's about it for side effects. The main thing that people are worried about are the allergic reactions. We have a whole system of screening people for anything that might be in the vaccine that they might be allergic to. And if that's the case, then they can't get the vaccine. And that's a really good reason for the rest of us to get the vaccine to protect them. And if you've ever had any history of a severe allergic reaction like hives or swelling, facial swelling, flushing, difficulty breathing, then instead of observing 15 minutes, we have everyone wait for 15 minutes for observation in case they might get an allergic reaction, which would happen in the first 5 or 10 minutes tops. And they're sitting there right where we have EMS, we have epinephrine, we have a code card, we have got a bunch of physicians. And the ones that have the severe allergic reaction, they have to hang around for 30 minutes. And again, so far, it's been extremely rare nationally of any allergic reaction since we started that screening. There was a few cases in the UK and in the US early on, but I think with the screening, it's been minimal. I don't know what the reports are nationally. So that's pretty much it for side effects. Certainly beats getting COVID. That's all I have to say. There's this robust post-approval or expedited approval monitoring system. This is just 2 out of 4 different systems. They take data nationally so this vSafe is coming directly from you. So if you get a shot, you download this app, and this links directly to the CDC, and you can report whatever you want to the CDC, and they're going to look at trends, and they can actually follow up with individuals directly through the app if they have more questions. And then from providers that are administering the vaccine or their primary care provider, they can report anything that they think is new or different or unexpected through this VAERS system. All that data is collectively coming into a central location that is being reviewed and analyzed every single week and reported out on every single week. So if there are any sort of trends that are happening nationally that are worrisome, then they'll know about it pretty quickly. I kind of already went over this. If you've already been infected, you should get the vaccine. If you get vaccinated, do you still need to wear a mask? Yes, because it doesn't prevent every single infection. You can get even if it's a much lower chance, you still can get like a mild case or an asymptomatic case. And it's also just hard to know who is vaccinated or not. And if you start walking around the street without your mask, it's going to get really confusing. So we still encourage people to wear a mask, but after the second shot, the full effect is 2 weeks after the second shot, you're going to feel a whole heck of a lot safer under that mask. It takes the edge off. You walk into a store, you're wearing your mask, and you don't have to think about what if by chance I get exposed to something, I could end up in the hospital. After 2 weeks after getting the second shot, the likelihood of that happening is minimal. So it really gives you some peace of mind. How long will these last? We don't know. There's lots of speculation that it could last years, but it's too early to tell, and it's too early to model this out. And we won't know probably for some time. So that's something that we have to keep an eye on. So I'm going to skip over. We talked about the allergic reaction. Pregnancy, the WHO just reversed their sort of precaution, like extra precaution about not getting vaccinated while you're pregnant. Women who are pregnant are at much higher risk of complications from COVID. And based on the way these vaccines are designed, there's no weakened or killed virus in it. And again, it's just based on the design with just the messenger RNA and that self-destructs and the salt and water solution. They think physiologically it poses very low risk. They say you definitely should, can consult with your OBGYN, but in general, on balance, they feel like the risk is probably better to get vaccinated. And if you're thinking about becoming pregnant, that's the best time to get vaccinated, because if you want to protect yourself while you're pregnant, while you have that higher risk, the best time to do it is before getting pregnant. And they believe that there's no concern in terms of breastfeeding, because the actual, messenger RNA doesn't pass, it self-destructs pretty quickly. It's not, the elements of the vaccine are not being passed through the breast milk. Does the baby get some of those antibodies temporarily? Yes, just like any, when babies are breastfeeding, it's like sort of getting an antibody bolus initially that they borrow from their mom, and that's nature's way of protecting the baby. But the antibodies themselves don't cause any harm. This is part of an immune response. And then there's one thing that we're working really hard on is, they talk about, there's people that are hesitant, and I just heard a talk the other day that instead of addressing resistance or hesitancy, really what we're doing is addressing institutional trustworthiness, right? So the onus is on us. The onus is on breaking down barriers, whether it's IT barriers or transportation, or just making sure that the knowledge gets out. It is grounded in years of institutional racism, of abuses in clinical research. So there's lots of reason why institutional trustworthiness has to be earned and worked on. And also people it's just human to want to wait to see what happens with other people. But my question would be, at what point would you be comfortable if that's the case? So we have, studies that had 30,000 people in them each. You have now 27 million people that have gotten some form of a vaccine. So I guess if you are waiting, then I guess the question would be to think about what you're waiting for and how does that balance in terms of your own risk if you do happen to get COVID for all the reasons above. But again, it should be done with humility, with those conversations with humility and compassion and active listening, and it should be just really part of an open conversation. So with that, and there's great tools from the CDC on sort of like some of the frequently asked questions and what are some, good answers for those. But I've talked way too much already, and I'm going to stop because I think the best part is, really let's bring out all the kinds of questions that you might have and see what you think is important to sort of address. So that was rapid and fast, and I apologize for that. But again, I wanted to leave enough time for conversation.
That's appreciated. Thank you. Now, how we're going to do this is going to be since we do have a number of guests in the audience, we're going to use the raise hand option. If you click on participants, you can see that there's a raise hand option at the bottom of that list. And we're going to go with committee members first. Okay, so. All right, Maria Luna.
Oh, thank you. My question is probably very simple. I have a cousin who she has the antibody. Her husband was in the hospital for 5 months with the virus, really, really bad. But she doesn't feel she doesn't need the vaccine. She feels that she can walk around. I mean, she wears a mask and stuff, but she walks around like nothing is happening. And I am trying to get her to get the vaccine. He also is hesitant to get the vaccine. Now, how do I convince them to, to go ahead and have this extra, this protection?
Hey, Ross.
Yeah, I think, so like I said, that having been infected and having antibodies, while certainly helpful in protection, and also I think it's fantastic that they're wearing the mask still, which is great, but it is not, we don't know how long that protection is going to last. And if they were already at risk, especially, and I'm sorry to hear about the 5 months of being in the hospital, that's really rough, really rough. especially because the visitation, it was hard to visit, and it was probably a very lonely time and scary. So I think if you're at risk the first time, and if you happen to get it again, that should be reason enough to try to do anything you can to prevent getting that again and ending up back in the hospital. These vaccines are proving to basically, if you complete both shots and you wait the full 2 weeks afterwards, that the chance of being rehospitalized because of reinfection is almost eliminated. It goes so low. So thinking back on their own experience, if they want to really be sure that that doesn't happen again, then the vaccine will really make a difference. So that's one way of sort of framing it in their own experience. I think, in my mind, I never try to convince, never try to coerce. It's more just really, obviously it's showing that you care by saying, I think you would be really great. But for now, they probably do have some protection. So that's a little bit comforting. But again, how long is that going to last? And for the fact that these are just super safe and effective. Really, millions of people have already gotten their first shot. So there's not much risk. I understand their hesitancy and concern because this is something that's new. And also, I think all of us have just heightened anxiety, period. We've gone through a really rough year, and just being understanding that people are just anxious. And when you're anxious, you're more risk averse. So it's very human to be hesitant, very human. But given what they've already gone through, you would hate to see that happen again. And I think that's probably the best way to approach it with them.
Thank you.
Yeah.
Joseph.
Oh, thank you. First of all, that was really a wonderful presentation. Would you feel comfortable sharing that with I'm taking minutes. Oh yeah.
I can,
okay. So
so I just I was told so I can send you a version like that in a PDF and later I'll send it over to the group. Yeah.
Okay. Wow. Okay. That's number one. Number two, just trying to understand the difference between someone who has antibodies who already had COVID versus someone who has antibodies built up from the vaccine. What I understand is that if you have the vaccine, you can still get COVID, you can still transfer COVID, but you won't hopefully get sick. So let's say you have a household and one person has the vaccine and the other one doesn't because they're in different categories. So then even the person who has the vaccine has to be very careful because they could still pick it up outside the home and bring it back home. First of all, is that true? And second of all, is that the same? My impression from people who already had COVID is that they can't even pick it up while they have the antibodies, so that when they wouldn't be able to infect anyone in their homes.
So to answer the first one is the reason why we're saying, oh, you still have to wear a mask and it's possible that you can spread it is because we don't want people to get to really let go of their masks. But in truth, it is highly likely, and we're very hopeful, that getting the vaccine drastically reduces your risk of getting infection in general, not just symptomatic infection, and also dramatically reduces your risk of transmitting it to others. We just don't have that data for these vaccines. The only one that I'm aware of that has some data to suggest that it does dramatically reduce transmission would be the AstraZeneca one, which is still going through the process. But it's likely that all of these vaccines help reduce risk of transmission, and they all don't reduce it down to zero. So they probably reduce it dramatically. We don't know that yet. But just like if you have had infection, that probably reduces your risk of transmitting it. Probably not zero either. So that's why we kind of say still use a mask and the social distancing and whatnot. And of course, if you're just with your family, you're not using those things because you're in your pod per se. So now we're getting to the issue of antibodies. When you get, if we go to a doctor and they draw our blood and they test you for whether or not you're protected against hepatitis B, what they're looking for is a particular antibody called the surface antibody, hepatitis B surface antibody. And if that's positive, then we know you're protected. Likewise, for measles, mumps, rubella, we have to go, our kids go back to school or going off to college, they want to get a titer. That's looking for those antibodies. If they're high enough, then we know you are protected. And if they're too low, then we revaccinate. We don't actually have enough science around what is the test that shows you're protected against coronavirus, right? We suspect that if you have antibodies, and again, there's different kinds of antibodies, so there's IgG and IgA and IgM, and so we don't know exactly that makeup. And also, it's not just antibodies that can remember what coronavirus looks like and attack it. There are, the T cells is like the conductor of the immune system. That's why, that's why HIV is so difficult, because that's what it attacks. You have B cells that are the ones that are the manufacturing of the antibodies. And then among the T cells, there's also this killer T cell that does the direct sort of engaging of the rest of the immune system to attack it. And we don't know what combination of all those things means that you are protected. There's no blood test right now that says, oh, we tested you, you are immune. We don't have that yet. It's called immune correlative protection. And that'll be really helpful once we have that, to know how long immunity is lasting, how long protection is lasting, because then you don't have to wait for people to get infected. You could just test their blood. So even if someone is antibody positive, is it likely that they're less susceptible? Probably, but we just don't have enough information about what level of protection that implies, and it's probably not zero. So in either case, I think in the sense of hedging your bets, if you were infected, you have antibodies. We don't know how long those antibodies are going to be around. We don't even know to what degree they provide protection. So all that to say, I think we're still recommending getting vaccinated. We think that
the question wasn't the recommendation. Of course you get vaccinated. I was just questioning if you have two people in a room, one has antibodies because they had COVID, and one has antibodies because they had the vaccine. Are they the same?
Yeah.
Right now?
We don't. The answer
that's
is
the answer. We don't know.
The answer is they are probably different, and we don't know what that difference is going to mean in terms of transmission. Yes. Right. Sorry, I overcomplicated it. So.
But you share. You added your credentials to showing how much you know about all these things. In the answer.
Sorry.
Yeah. Glennis, you're next.
Thank you so much for that great presentation. It was extremely informative. So my one question is, do you think that we'll have to get revaccinated every year?
Yeah, the scientists, so it mutates, so the general mutation rate is about a third the rate of the influenza. And it also matters what part of the virus that mutates. The one that matters for the vaccines is that protein sticking out. So even if it mutates every 3 years as quickly as the flu, it may not actually impact the protein that we're targeting that much. So unlikely that we'd have to be vaccinated every year. Could it be every 3 years? Could it be every 5 years or beyond? Again, we don't know. Yeah.
And speaking of the mutations, the ones that they're talking about now that have popped up around the world, South Africa, Brazil, how effective is the current vaccine against those? Or is it all the same?
Great question. And it is not the same. They're probably the strains, the vaccine in terms of effectiveness against the strains are all not going to be impacted very much in the sense of preventing severe disease and death, which is the main thing we're trying to prevent. Whether it prevents all infections, there might be a slight impact. And we already have, the only one that we have clear data on is the one that's in review right now. That's the Johnson & Johnson or the Janssen, from the Belgian or Dutch, I can't remember. But anyways, that's like a one-shot thing. That one they actually tested in South Africa and in outside of South Africa, and the effectiveness was lower by almost 20 points. Still very effective, still higher than the threshold for approval, but definitely lower in the South African cohort, and that's for all infections. But in both groups, people that got vaccinated didn't get really sick and didn't die. So in terms of those endpoints, it's really effective, but there's a little bit of a drop in effectiveness in terms of preventing infections. That's the only one that's been tested truly. They do speculate that, again, without real world knowledge, but they do speculate the way the mutations are in those proteins and the South African strain and the Brazilian strain, there might be a slight decrease in effectiveness for the Pfizer and the Moderna, but that's just speculation, and not so much in the UK. So while all of them tend to spread quicker, like the UK, that the Pfizer and the Moderna should still be effective against the UK strain as far as we know so far, like equally effective.
Great, thank you so much.
Yeah.
Okay, Richard.
Again, thank you. I was taken by your comment about allergies, that for people who have allergies that keep them from the vaccination, from being vaccinated, it's a way to say that the rest of us are protecting you. The reason I raised that, a few of us were in a conversation the other day about young people dissing old people and saying, why should they get the vaccine? They're just going to go away or whatever. I'm asking to go a little beyond allergies. Are there other ways you see to message towards young people, younger adults, that getting this vaccine protects people like them, as well as the rest of us?
Yeah. Yeah, the allergy thing is not a big one because there are hardly anyone that gets the severe allergic reaction, that have that stuff and can't get it because of that. That's going to be a tiny minority. That's a tough one. I think, I have kids in college, and my guess is that there are people in their lives that aren't necessarily old, that they love, that are at real risk. All it takes is being a little overweight, of having high blood pressure, of having diabetes, maybe getting pregnant, that's another thing, that are people immediately around them that they really care about, that if they got COVID, bad things could happen. And I personally, like when I was in the tents, there was this desperate mother that came in wanting testing because she wasn't allowed to see her 17-year-old. All that 17-year-old had was a mild case of asthma and was just a little bit overweight and was intubated. And she had COVID and she wasn't allowed to visit her 17-year-old, and she was a single mom. So there are kids, it's not just like, we had that congressman who was 41 who had very little complications, died, right? So this is no joke. And there's also long-term complications that we still don't understand. And do they want to risk something that might give their kidneys a hit or their heart a hit or change there's something about their blood vessels that could be long-term that we just don't know about? So there are things that they might feel fine, but we don't know if there might be some long-term effects. And there are definitely people in their lives that they could probably identify that if they were to by chance spread it to them, they could put that person at real risk. That's the only thing just off the top of my head to really personalize it. But it's obviously a tough one. That's probably not helpful because I have a young one, and I feel like I sound like the Charlie Brown teacher that there's no words coming out, the wah wah wah. So you can say anything and nothing gets through.
Yeah. Okay, Alana.
Hi. So Riverstone is going to become a rapid testing site just for one day as a trial for just seniors. And I'm wondering if anybody's going to show up at all because they will have been vaccinated. And we're hearing that even if you are vaccinated, you should get tested. But, we'll give it a try. But what do you say about that? That you got the vaccination, and how do you encourage people to get tested anyway, if we should?
Are these folks, are these residents in a residential situation, or is it more serving elderly in the community that would be coming in.
It would be both. You know, there'll be signs put up around, and so whoever comes in would get tested. I'm just thinking no one's going to show up. That's beside the
Yeah. Yeah, I mean, I guess I can't really speak to like what the science is in terms of the value of testing for residents. You know, like sort of active surveillance is what you're doing if you're testing some people that are living together in a congregate living situation.
No,
And there
no,
might be-
if they are living, it's a regular senior building, so it's not a nursing home
Yeah.
or anything like
Right.
that.
Yeah, I mean, if they're 2 weeks out post their second shot, which is not still a minority, I'm not sure. I don't know the answer to that about how important it is to get tested if you don't have any symptoms at all, or if you have
And you
no
were
known
vaccinated.
or no known exposure. Like you, absolutely, if you were in the same room with someone that recently got diagnosed, then you should definitely self-isolate and get tested. If you have any symptoms, if even mild ones like a mild headache or that is unusual, or loss of taste and smell, or anything like that, then
Sure.
yes, definitely get tested because you might have it and be spreading it. But truly asymptomatic, not really exposed, and vaccinated, I'm not sure about that.
Okay, well,
Yeah.
we're going to give it a try, and then we'll
Yeah.
open it up to the younger community,
Right,
which makes
right.
more sense, I think. Okay.
Yeah.
Can I just ask one other quick question? I don't know, I think it's a quick answer also. I just was wondering if we're trying to get this out as quickly as possible, why are the centers not open 24 hours a day or 20 hours a day? In other words, I've seen places that they're getting it out, we're moving through, but it doesn't seem like an emergency. Like we're trying to get to as many people as possible. And I know there's a limited amount of vaccines. I get that. So you'll run out earlier, but you'll get more people vaccinated quicker. Does that not make any sense? It's been on my mind for the last 2 weeks.
Yeah, I mean, I know they just opened up the New York Yankees Stadium, right? So that's going to be like 15,000 a week, I believe.
So you
so I
can't do
think
more than
and more
that,
of the-
though?
Pardon? Yeah,
They can't
well,
do more?
I think you're right. It's probably supply driven. I know that's definitely the case for the Armory. And honestly, we open our doors at like 6 a.m. and we start having people come in around 7. And when you get to around 7:38, there's people not coming in, and we actually have teams of people calling patients that we know that are at high risk and saying walk in. And we actually opened up for the priority. This wasn't the case in the first few days, but it's becoming more the case. And we have a list of priority zip codes in Washington Heights, Harlem, the Bronx, the boarding zip codes, and that are allowed to do walk-in, to help fill the slots that might be from no-shows. So then it's crickets, honestly.
So it's like even people who are not in not 1A or 1B. What if someone was not a category? Could they just stand outside and say, "Is there an open vaccine?" If they're healthy and they're 40 years old?
Well, the supply is, we have supply in the freezer, then they go into a fridge, and then they go into syringes, and then we have 6 hours to get into arms. And they don't want to take anything out of the freezer that's not going to end up in the arms of the designated. And we're using every single dose. Like there's hardly a wasted dose. They do this whole process, like at a certain point, is we see someone coming, getting registered, then they start preparing it. And they want to make sure, also they have to preserve, they're matching the supply in terms of dose number 2. So if you get dose number 1, you got dose number 2 protected. So there's a lot of those kind of complications, and they want to stick to getting it to the most vulnerable first. Yeah. I mean, there's been a few cases where people that are volunteering in the Armory that are in other categories, but because they're taking care of patients, they're put in the healthcare category, and if we have doses that otherwise would get wasted, they're getting them. So that's the only group that I would know that is younger that is getting it, but it's sort of like in the healthcare category.
So it's also been people who accompany somebody toward the latter part of the day, where they know that they're going to have some extra doses, because I know a few cases already.
Oh, really?
Yeah.
Oh, okay. I have not heard. I've not in the Army. I've not gotten directive for that. And
Yeah,
I had
no,
one like
I
that.
don't know. I don't know how it's happening, but I do know
Okay.
that there are people between 60 and 65 who brought their parent or whatever, and they were offered the vaccine and they've taken it.
Oh wow. Okay, because I had a case just like that last evening, and I knew I wasn't allowed to do that. So
Yeah, so somebody did it.
yikes. Yeah, it's like Soul Cycle. Yes. I think Shuli, did you have your hand up for a while?
Yes, good morning again. Thank you so much for the presentation. There is a question I'm trying to get the answer to, and I haven't really gotten a definitive one yet, and that is, what does someone do? What's the protocol or the recommendations if they have received dose 1 of the vaccine and they come down with COVID? What are they doing to schedule dose 2?
Great question. So you could have, dose 1 doesn't have full protection, especially in the first few days after dose 1. You can definitely get COVID. Let's say you get symptoms, so they would have you wait until at least 10 days since the onset of the symptoms. You don't have to be completely symptom-free. You just have to have symptoms that are improving and no fever. And then if it's been at least 21 days or thereabouts, then you get your second shot. Now, if it gets delayed because of it, that's not necessarily a bad thing. Actually, there's pretty good evidence that delaying the second shot might even give you a better immune response. So that's certainly the case that they think. The data for AstraZeneca, that's going to be interesting thing what the FDA recommends for that. That sometimes waiting longer, you get an even better boost. If you get it too early, you might actually compromise the immune system a little bit. So if you get it in 2 weeks instead of 3 weeks, you could compromise the boost. So
like
if it happens, pardon? So no problem waiting.
No, but there isn't a recommended extension because of COVID beyond when you're symptom-free.
Yes,
like I know people who've received convalescent plasma or something, they're recommended to wait, I think, 90 days before getting vaccinated. So I was wondering if that's the same thing if someone gets COVID during their cycle.
The only thing I know of is 10 days post the onset of symptoms. You don't have to be symptom-free. And then if you're over 21 days, you can go ahead and get it. And it shouldn't, in that case, you're probably getting a double whammy in terms of stimulating the immune response, and you're probably getting a really great immune response because the virus is causing some immunity, and then on top of that, you're getting a booster from the vaccine. So I don't see physiologically how that would compromise the immune response unless there's some interaction that I'm not aware of.
Much.
Okay, I have a couple of things on the chat.
I think Alana's been trying to.
Sorry? Oh, okay. I thought that was an old raised hand. Sorry. Go ahead, Alana.
Two things. Now I'm going to forget, right? When do you think the next phase will be instituted in terms of age, a younger age group? When do you think that's going to happen? And then the other thing is, in connection with what Shuli said, what is the outside time frame for the second vaccine? So usually they say within 3 days, I think I heard, but what if somebody can't for whatever reason? A month later, 2 months later, is there any efficacy in that?
Yeah. So in terms of opening up to younger age groups, so like if you're a 60-year-old diabetic with hypertension, it'd be great to get. I'll be honest with you. I don't know enough about the supply chain and the rollout and what.
Okay, so we don't know.
Yeah, that one, I mean, I don't know. There may be more information from the state and Cuomo to give some projections on that, but I haven't just in hearsay, I haven't heard anything. In terms of too long out, I would actually have to check whether there is, because it's what the FDA says and what the clinical, guidelines are and what the science is. So from the science standpoint, what I've heard is that again, it might be different for different vaccines, but for the AstraZeneca, you could wait 3 months after the second shot, and you'd actually have a fantastic immune response. And so if you follow that, there's a likelihood that if you ended up getting it, 2 months late, so that 3-month mark, in all likelihood, you would get a pretty fantastic boost from that as well. Now, whether they would allow for that because of guidelines and it's not FDA approved for that and it's kind of off-label, usually, those things are considered off-label and they would they would fudge with that and like, oh, things happened and you didn't get your second shot. The downside of getting the second shot is probably minimal, and the upside is that you would still, probably get a pretty decent immune response over just getting the first shot, even if it was 3 months out. But again, I don't know if I should know this, but clinically whether there's an outer window where, okay, now it's 4 months out, we're not going to do it. But scientifically, at least 12 weeks from the first one, there's no reason to believe that it wouldn't create a really decent boost.
If you get a blood test, can you see how many antibodies, if you're in a good response or not a good response?
There's no good test to evaluate your level of protection from a blood test. Yeah.
Okay, I'm aware of the time and we do have another presentation. However, I have somebody in Ebenezer, you can help me out with this. Cheryl Miller wants to be able to ask a question. I don't know if you can upgrade her.
I see one where it says Cheryl Miller is asking if you need to get a second shot or won't. So people still need to get second shot or won't get full efficacy.
Well, I think those questions were answered. It's the last one, and she says, "Mary, can I ask him a quick question?" So
okay.
Mary, who you wants to promote to speak now?
Cheryl Miller.
Okay, go ahead, Cheryl.
Thank you so much. Can you hear me? Good morning, everybody.
Yes, yes.
Yes, we can hear you.
Thank you for allowing me to ask a quick question. So, Dr. Chang, I had a quick question to ask you. I went to the Armory 2 weeks ago and I got my first shot. And I am still getting body aches and some fatigue. I did call my doctor yesterday and he is advising me to still get my second shot, not to let that go, because if I let it go, I'm going to have to wait, and go through the whole thing all over again. And what I have heard is that a lot of people get mild stuff after the first shot, but after the second shot is when you really get more of effects. So I'm thinking, am I maybe the opposite? I'm getting a lot of response now to the first shot, and then my second shot, I'm not really going to get anything. Also, the other question is, I took Tylenol yesterday, but I don't want to be living on Tylenol every single day because it's not good for your stomach. So what would you suggest? Just ride it out and the body aches will obviously go away. And the fatigue, I'm sure, will go away.
Yeah, that's so first off, to have ongoing body aches and fatigue that far out is highly unusual for the vaccine. And so so the first question in my mind is there a possibility that something else is going on? And if it were to happen to me in a healthcare setting, they would require me to get a swab to rule out that whether I got a COVID infection in the meantime or something. I mean, there can be other viruses that can cause things like that. So again, I'm not saying it's not the vaccine, but it's highly unlikely, even though it's coincidental in terms of the timing. And again, we're still learning, so it's entirely possible it's all the vaccine. In terms of whether or not you got because of the symptoms, it's a sign that you got some fantastic response, you don't need the second one. symptoms don't necessarily correlate with either effectiveness. So it's just some people, when their immune system is stimulated, some people get symptoms and others don't, just like the flu shot. But it doesn't really have any bearing on whether you had a more effective response than not. You are absolutely right. You can get there's a higher chance of getting symptoms on the second time around. Again, it tends to be not severe, and it tends to last like 36 to 48 hours, even if you do get some more symptoms. And it would give you that protection, the full protection, that one shot, but based on the data, does not. Like the one shot will give you a pretty good, decent amount of protection, but the booster is what really gets you there. And also the booster might be helpful in terms of duration. So it's not just the short-term effectiveness, but getting the booster might give you the long-term effectiveness, which you would want later on down the line, like a year later or more. You'd want to have known that you've got the booster if that's the data that comes out. So I agree with your doc that, you know, unless you're feeling really ill, fever, and if you just have mild symptoms, and you're getting to that 21-day period and you're feeling otherwise okay, and you know, consider getting the second shot, but also consider getting if you're concerned about any exposures you might have had, or you know, knowing your own, you know, what's been happening lately in the last in the days before the vaccine. You might want to get a swab and get tested to make sure you didn't pick up.
I just recently did, and I was negative, but also I have been socially isolating myself since all of this. I only go out if I absolutely have to. Right. And for the most part, I've been staying in the house, and I live alone. Nobody else lives with me, so I'm not concerned that it's COVID.
And the Tylenol is sort of like, you know, the Tylenol is not going to cause you, you know, unlike the non-steroidals, it's not going to cause you, sometimes it can upset your stomach, but it's not going to cause an ulcer. The one thing that if you overdo it, you can affect the liver, so you have to be very careful not to go over 3 grams in a 24-hour period. So that's like 6 extra strength doses, so that's quite a bit. But otherwise, Tylenol is fairly safe unless you have underlying liver disease.
Okay, thank you so much, doctor. Thank you. Thank you for taking my questions. Thank you.
Yeah, of course.
Thank you very much for this interesting and informative presentation, and I really appreciate your time, Steve. We're going to move on now to our second presentation, which is going to be a little shorter than we'd hoped for. We have to end at 12 because that's the only amount of time that we have on this Zoom link. So, Chris, go.
Sure. Hi, everybody. It's Chris again. So last time we spoke about the senior wellness calls. I've corresponded with a few of you since that point. Just want to offer a few clarifications, and then if you have any questions, I'm happy to engage. But ultimately, we'd love to have CB12's support in if you have folks on the committee who'd like to volunteer with us, if you can help us spread the word. We're making these senior wellness calls to anybody over 60 in the district, which Senator Jackson's district obviously spans from Marble Hill down to Chelsea. So we have, I think, about 12,000 folks in CB12, and then smaller numbers in CBs 9, 7, and 4, and a smaller number still in CB8 in the Bronx. So we are using Call Hub, which is a very easy software. You just, log in with your email, create an account. All you need is your email and your password, and then you log in from any device, and you can just start calling based on the campaign that you've been assigned to. And so that is the framework. The questions are very basic. We aren't trying to achieve the same kind of completeness that a lot of the DIFTA questions really try to go for. I see Fern nodding her head. And we
sent it to you.
We spoke about this, and it was very helpful to see, and it helped us realize that we are doing slightly different efforts. And so as far as merging of lists that we discussed, maybe wanting to look into last time, we're not going to do that. We're just
it doesn't make sense.
Yeah, we're going to do a separate thing. But we are, of course, going to feed into the senior center pipelines, where one of the last questions we ask is, are you involved with a senior center? And if not, would you like to be? And if so, can we share your email address with our local our local senior centers. And
Mhm.
so the hope would be that as we get through these lists, you'll start getting updates from us about names and phone numbers of people that may not be on your list yet, or if they are, they don't know they are. And
Right.
then you all can do with those as you will, but we're going to pass them on once we have the consent from the folks that we're talking to. So that's a
Okay,
quick and dirty overview. I'm happy to answer any questions or discuss further.
any questions, anybody, for Chris?
Just to let you know, Chris, right now, I would say our senior center, and lady, Julie, please jump in with your opinion, Alana. But I think we're overwhelmed right now with calling people about getting them appointments for the COVID vaccines.
Sure.
I know that I'm getting calls every day, multiple calls every day. Maria is lovely enough to provide me with lists every day as well of people who have said yes to her so that I can reach out to them and actually make the appointments. And so right now, I think our group is probably at capacity.
Sure.
What do you guys think, Lady, Julie, Alana? I see nods. My colleagues are nodding. It's just a lot right at this moment. So I, for one, am deeply appreciative of you getting your volunteers to do this and sending us names. I think that that's a great partnership right there.
I hate to say this, but I have a list of over 125 people to submit that for, scheduling, the vaccine. But I'm looking at the screen here. I love to see Shirley. She's multitasking. She's eating, she's taking care of the baby. She's attending to the meeting. I think that she's a true women.
A poster child, right?
My God, I love to see that. I'm watching her.
I see you.
It's fantastic.
Love it.
And thank you, Fern, for everything that you are doing. You're being fantastic. I mean, you're being fantastic.
Thank you.
Also,
Thank you, Maria.
Ilana,
Maria,
okay.
I just, while we were on this call, I got a call from Univision about our efforts on the vaccine. I'll call you afterwards. I would like to speak to you about your experience and your knowledge.
All right. Whatever.
I figured that you're comfortable in front of a camera, no problem.
Okay, so just a couple of things. For March, I have scheduled a presentation by Dr. Orly Hauser on the Wurtzweiler's Care Cafe.
Fantastic.
So that will be our presentation in March. And the other thing I want to tell the committee and others is that I won't be going anywhere this March because my Aruba roommate is in the hospital for the past 16 days with COVID.
Oh, no.
And
I'm
I can't
sorry to
afford the
hear
whole
that,
room by
Mary.
myself, so it's like, okay.
Mary, this is Maria. Maybe you should consider, I know that we don't want to get political on this thing, but as of the primaries that are going to be Republican and Democrat on June 22nd, the new ranking system of voting is going to be starting. It was already started in New York and the last week, but we need to inform the seniors how to use the system, how to vote. Extremely important. We need to reach out to everybody to make sure that they do the right thing and that, each vote counts. So maybe you should include a little bit of that in one of your, your next meeting, maybe. It's extremely important. You need to go out by, in March, that information.
Maria, would you be willing to also present briefly at Waikoa on that?
Sure. I did a television show last night with Naleo with Juan.
Juan Rosa.
But it's on YouTube. But we need to get out, this information to every voter in New York, and especially the seniors, that are using the paper ballot, some of these people who are going the absentee ballot, that they need to know how to do this in. So I need to, we need to get in touch with everybody, as many people as we can. So
Do you think we should have that in March as well?
I hope so. I hope so.
Who, all right,
It's
let
not
me
gonna
know.
be long. It doesn't take long to do
okay.
that, but it's extremely important, Mary.
Okay, so, get me the information as who to contact, okay?
Okay, I will.
All right, thank you. And, who else? Richard, you had your hand.
Real quick, I was just going to add an exclamation point to that and suggest that you also take it to the executive committee with the possibility of mobilizing the whole organization, the whole community board and its committees to work on this with a first focus on seniors, of course.
Yeah, okay. Anything else? Verna, are you still on the call? I don't think so. I think we lost Verna. I was going to ask her if she had any comments, but I think she's off the call.
Okay,
So
I'll call you back. Okay, bye-bye. I hear you talking about me, Mary. What did you want?
no, Verna, I was saying I didn't
Oh,
know. if
Verna had to go off. She sent me a
Okay.
text
Oh, okay,
that she had a pre-scheduled 9:30.
got it. Okay, so unless anybody has anything else to say, I'd like to.
Mary, spectacular. Thank you. Thank you again, Stephen, for your efforts on our behalf. And I love this committee. I keep coming because I love it, not just because I'm a public member.
I'm sure glad you do.
And Dr. Chang, you have Mary's email address for the presentation?
I'm sorry?
Okay.
Oh, yeah. Can you send it?
Oh.
I mean, Stephen, are we allowed to distribute the PowerPoint that was given out at Waikoa as well? You're on mute.
You're on mute.
Sorry about that. Yeah, I just checked with, all the powers that be, government affairs and whatnot. So we can definitely send it out. The only thing, I have to create a quick slide of a caveat at the end or disclaimer and convert it to PDF, and then I can push it out. And there's a patient-facing version. We have patient-facing versions in English, Spanish, and Chinese so far. They're working on French. Hopefully that'll be sufficient for French Creole. And then the one I gave is more for leaders in the community like yourselves, because it gets a little bit deeper on the data and the science. None of the presentations are ideal, but that's what we have for now. So as soon as I probably won't get to, because I'll be vaccinating in that church all day tomorrow, and this afternoon I'm at the Harlem United Clinic. So probably not till tomorrow afternoon I'll be able to attach some kind of that disclaimer, PDF it, and then push out the different versions, and then you can do whatever you want with it.
Thank you. Thank you.
Okay.
So Mary, I'm going to ask you to forward it to me as well, because my staff, which participated with Dodie, have been asking me if it was okay to send them a copy. So
Okay.
yours is really the same. So
Okay.
if you could just send that out to me, I'll distribute it to my staff.
Good.
Thanks, everybody. I have to go. Bye.
Okay, Chris. So
Good
do
to
we.
see you, Chris. Thank you.
We'll get cut off soon. All right.
Take care.
Okay,
Closing
I'm
this
calling you,
meeting.
Maria.
Take care, everybody. Stay
Okay,
well
thank
and
you.
safe.
Good to see you, Glynis.
Take care,
Bye,
Mary.
all.
Stay strong.
Okay.
Bye.